This is a summary of the CPIC guideline for serotonin reuptake inhibitors and variation in the genes CYP2D6, CYP2C19, CYP2B6, HTR2A, and SLC6A4. This video will specifically discuss the recommendations for citalopram and escitalopram. Videos covering the recommendations for fluvoxamine, paroxetine, sertraline, venlafaxine, and vortioxetine can be found on the PharmGKB website and on the PharmGKB YouTube channel. This guideline was last updated in July 2023. Patients with increased CYP2C19 activity are less likely to experience a clinical benefit from citalopram or escitalopram, while patients with decreased CYP2C19 activity may be more likely to experience side effects. Because of this, the guideline recommends that an alternative drug be considered for patients who are CYP2C19 ultra-rapid, likely poor, or poor metabolizers. There are currently 39 defined alleles of CYP2C19 known as star alleles. More information about CYP2C19 star alleles can be found at the PharmVar website and in the CYP2C19 gene information tables on the PharmGKB website. Links to PharmVar and to the gene information tables are given in the description below this video. Star alleles are characterized by their rate of function relative to the star 38 allele, which matches the CYP2C19 genomic reference sequence, or the star 1 allele, which is commonly used as a comparator in functional studies. Both star 38 and star 1 are designated as normal function alleles. Diplotypes of CYP2C19 star alleles can be assigned to a metabolizer phenotype, as shown in this table and in Table 1 of the guideline. There are limited data available to fully determine the relative function of CYP2C19 decreased function alleles. As a result, patients carrying decreased function alleles are assigned as likely intermediate metabolizers or likely poor metabolizers. Note that as more evidence becomes available, new star alleles can be added and the functional definition of some star alleles may change. An important caveat for all genotyping tests is that a normal function status is given to all alleles which are not detected in the assay. This can include rare increased function, decreased function, and no function alleles which are not routinely screened for in some genotyping tests. This image is adapted from the PharmGKB citalopram pathway. A link to the original pathway is provided in the description below this video. Citalopram is a racemic mixture of the isomers R-citalopram and S-citalopram, with S-citalopram providing the clinical effect of citalopram. The S-citalopram isomer is also the active ingredient in S-citalopram. S-citalopram is metabolized by liver enzymes including CYP2C19. This metabolism reduces the activity of citalopram and escitalopram. In CYP2C19 ultra-rapid metabolizers, the metabolism of escitalopram is increased. This reduces the plasma concentrations of escitalopram and increases the probability of pharmacotherapy failure. In CYP2C19 poor metabolizers, the metabolism of escitalopram is reduced. This increases the plasma concentrations of escitalopram and puts the patient at risk of side effects. These are the CPIC recommendations for citalopram and escitalopram. Patients with the CYP2C19 ultra-rapid metabolizer phenotype will have increased metabolism of citalopram or escitalopram compared to normal metabolizers, and may have a decreased probability of experiencing a clinical benefit. An alternative drug that is not predominantly metabolized by CYP2C19 may be considered for these patients. If citalopram or escitalopram are clinically appropriate and the standard maintenance dose does not result in adequate efficacy, consider titrating to a higher maintenance dose. This is a strong recommendation. Patients with the CYP2C19 rapid metabolizer phenotype will have increased metabolism of citalopram or escitalopram compared to normal metabolizers, and may have a decreased probability of experiencing a clinical benefit. Therapy with citalopram or escitalopram can begin at the recommended starting dose. If the patient does not respond adequately to the recommended maintenance dosing, consider titrating to a higher maintenance dose or switching to an alternative antidepressant which is not predominantly metabolized by CYP2C19. This is an optional recommendation. Patients with a CYP2C19 normal metabolizer phenotype will have normal metabolism of citalopram or escitalopram. These patients can initiate citalopram or escitalopram therapy at the recommended starting dose. This is a strong recommendation. Patients with a CYP2C19 intermediate metabolizer phenotype will have reduced metabolism of citalopram or escitalopram as compared to normal metabolizers. This may increase the probability of side effects due to increased plasma concentrations of citalopram or escitalopram. These patients can initiate citalopram or escitalopram therapy at the recommended starting dose. A slower titration schedule and lower maintenance dose can be considered. This is a moderate recommendation. Drug-drug interactions and other patient characteristics should be considered when adjusting dose or selecting an alternative therapy. Patients with a CYP2C19 likely intermediate metabolizer phenotype will have reduced metabolism of citalopram or escitalopram as compared to normal metabolizers. This may increase the probability of side effects due to increased plasma concentrations of citalopram or escitalopram. These patients can initiate citalopram or escitalopram therapy at the recommended starting dose. A slower titration schedule and lower maintenance dose can be considered. This is a moderate recommendation. Drug-drug interactions and other patient characteristics should be considered when adjusting dose. Patients with a CYP2C19 likely poor metabolizer phenotype will have reduced metabolism of citalopram or escitalopram as compared to normal metabolizers. This may increase the probability of side effects due to increased plasma concentrations of citalopram or escitalopram. A clinically appropriate antidepressant that is not predominantly metabolized by CYP2C19 should be considered. If citalopram or escitalopram are clinically appropriate, consider a lower starting dose, slower titration schedule, and a 50% reduction in the recommended maintenance dose. This is a strong recommendation. Patients with the CYP2C19 poor metabolizer phenotype will have reduced metabolism of citalopram or escitalopram as compared to normal metabolizers. This may increase the probability of side effects due to increased plasma concentrations of citalopram or escitalopram. A clinically appropriate antidepressant that is not predominantly metabolized by CYP2C19 should be considered. If citalopram or escitalopram are clinically appropriate, consider a lower starting dose, slower titration schedule, and a 50% reduction in the recommended maintenance dose. This is a strong recommendation. When prescribing for CYP2C19 likely poor or poor metabolizers, be aware that the US FDA has issued a warning that CYP2C19 poor metabolizers receive a maximum citalopram dose of 20 mg per day due to the risk of QT prolongation. Patients with hepatic impairment taking a CYP2C19 inhibitor or over 60 years old should also receive a limited citalopram dose of 20 mg per day. There is no recommendation for patients with a CYP2C19 indeterminate phenotype. The recommendations for citalopram and escitalopram can be found in Table 3 of the guideline. This guideline has been annotated on the PharmGKB website. This includes a drop-down menu where a specific recommendation can be given for given combinations of alleles. This includes implications for the patient's response to citalopram or escitalopram, the appropriate recommendation for the specific metabolizer phenotype, and the strength of that recommendation. Remember that variation in other genes in addition to demographic and clinical factors, including concomitant medications, can affect treatment. It remains the responsibility of the clinician to determine the best course of treatment for a patient. CPIC and PharmGKB assume no responsibility for any injury to persons or damage to persons or property arising out of or related to any use of CPIC's guideline or for any errors or omissions. The guideline itself and supplementary information are freely available at the PharmGKB and CPIC websites. You can access relevant pages using the links in the description below this video.